This presentation will introduce the concept of sedation in the critical care setting. In this presentation, we will define the purpose of sedation and reasons patients are sedated, identify nursing roles in relation to the sedated patient, and identify nursing considerations for select medications used for sedation. Many patients you'll encounter in the ICU are sedated. Some are undergoing bedside procedures that involve brief conscious sedation just for the duration of that specific procedure, and some patients in the ICU receive continuous titratable sedation drips. When talking about sedation, it's always important to start with why. Why are patients being sedated? In general, the goal of sedation is to establish a state of calm. Sedation decreases level of consciousness. Now, why might patients need to be calm or have a decreased level of consciousness? Well, this can relate to maintaining patient safety, minimizing patient discomfort, whether that's physiological and or psychological comfort. And at times, patients are sedated to control behavior. Many patients are so sick that if they were awake or even fully aware of what was going on, their body's response to their current state could interfere with important interventions. Keep in mind, just because a patient is anxious, that does not mean they need to be sedated. Sedation is a very serious intervention, and the team needs to determine that the benefits outweigh the risks. For example, consider a patient who is not breathing effectively, and now that patient has to be intubated and placed on a mechanical ventilator to survive. Having a tube inserted into your airway and being connected to a machine that is now forcing air into your lungs can be very uncomfortable, and most people's bodies would respond to that with a sympathetic response. Further, some patients may have other comorbidities or issues that cause confusion, so they're not aware that these devices or interventions are intended to help them. If we're not able to implement these life-saving treatments without a patient interfering, sedation can be critically important. Therefore, one of the most common reasons a patient is sedated in the ICU is to facilitate mechanical ventilation. Some sedative medications can also cause amnesia or memory loss. And while this sounds like a negative side effect, it can actually be beneficial in some cases. For example, if a patient is to undergo a traumatic procedure, there's definitely some benefit to the patient not remembering the procedure while also being sedated. Another key distinction to make is that sedation is different from analgesia. Some analgesic medications like fentanyl can have sedating properties where they cause CNS depression. However, sedation on its own is not equivalent to pain control. Patients may appear unconscious or unresponsive when sedated, but if the medication they're receiving is just a sedative, their body can still experience pain, and therefore their body can also suffer the negative side effects of pain, even if we can't interact with them. Now, before we discuss specific medications, there are some important overarching principles related to continuous sedation that every ICU nurse needs to understand. First, patients can develop tolerance and even a dependence on sedating medications over time. Therefore, patients may also demonstrate withdrawal to a continuous IV infusion of a sedative if it's stopped. Depending on the drug, there may be strategies the team can implement to reduce that risk. Also, even though a patient may look very calm and relaxed while receiving continuous sedation, these drugs can often reduce the quality of REM sleep. When we don't get enough REM sleep, this can impact memory, learning, and potentially lead to delirium. In general, continuous sedation is actually quite a tricky balance. We don't want to over-sedate our patients. This can make it even more difficult to eventually get them off of a mechanical ventilator, for example. It can increase their length of stay, and it can put our patient at a higher risk for a number of complications. Remember, ultimately, we want our patients to be awake, participating in care, and getting out of the ICU. Over-sedation can interfere with that goal. Now, under-sedation can be equally problematic. Patients who need to be appropriately sedated, but are not, can be put in a hypercatabolic state, increasing stress and increasing the sympathetic response. This can lead to hypercoagulability, immunosuppression, increased oxygen demand, and ultimately interfere with important therapies. Therefore, you can imagine that it's important to find that sweet spot or target level of sedation where our patients are not over-sedated and not under-sedated. Therefore, we need helpful tools to guide our practice and help find that balance. Now, in most cases, the goal of continuous sedation is for the patient to achieve a state of calm, but to also be easily arousable. We're trying to reach that goal with the lowest possible dose of a sedative agent with the lowest possible risk of harm to the patient as well. As with any continuous drip, patients who are receiving continuous sedation require frequent nursing assessment. If the goal with this continuous sedation drip is to sedate our patient, we need a clear and effective way to assess that level of sedation. Now, different facilities may use different scales to assess sedation, but two of the most common are the Richmond Agitation Sedation Scale, or the RASS, and the Ramsey Scale. Now, upon observing the patient, the nurse determines the level of sedation while referencing the scale specified by the provider. They next review the continuous sedative medication order and determine whether or not the patient has met that goal. So, for example, let's say a patient were receiving Midazolam for sedation and had a goal RASS score of -1. The nurse walks into the room and notes that the patient is wide awake, reaching for the endotracheal tube, and appears anxious. So, following the protocol, the nurse would increase the sedative medication drip rate. On the other hand, if the nurse were to find the patient didn't respond at all to the nurse when spoken to or repositioned, the sedation drip rate would be turned down per protocol to try to meet that -1 RASS score goal. So how do we sedate our patients, and what do we need to think about once our patient is sedated? Patients who are continually sedated in the ICU, for example, those who are mechanically ventilated, they can receive a number of different sedating medications via continuous IV infusion. Now, different providers may prefer one medication over another, and different sedative medications may be more effective or more appropriate for different patients when we consider their bigger clinical picture. So let's take a look at some very common sedatives. Now, keep in mind, this list is far from comprehensive, and depending on your facility, you may see more or less of certain medications, and you may see medications that are not even discussed here. Just keep in mind that orders for these medications follow those basic guidelines of all continuous IV infusions, where we need a provider order to include a clear starting rate, indications for titration and parameters for titration, goal parameters, and a maximum rate. Ideally, a sedative has both analgesic and sedative properties. Also, an ideal sedative has a rapid onset and offset. Now, why might that be? Well, a quick onset is helpful when we need to see quick results, when we need our patient to quickly and efficiently be calm so that they can benefit from this state of calm. Also, if we do want to wake up our patients and turn off the sedation, we don't want to have to wait for hours and hours on end before our patient is finally awake. So as you can imagine, we would like our patients to eventually wake up, get better, and participate in their care. So fentanyl is a very common continuous IV infusion in the ICU, and this is because it has a rapid onset and offset and is an analgesic. And it also has sedating properties. However, fentanyl does not always provide sufficient sedation for a patient. So we may see patients receiving a continuous fentanyl drip and an additional continuous sedative drip. In this lesson, we'll talk about fentanyl, midazolam, propofol, and dexmedetomidine. Again, keep in mind these are very brief overviews of these drugs, and that you should always consult a drug reference before administering any of these medications. So starting with fentanyl, fentanyl is a very potent narcotic analgesic, and thus you will see it dosed in micrograms. It has a very rapid onset, usually almost immediately when given IV. So keep in mind that the respiratory depression effects may not take effect for a matter of minutes, though. Fentanyl's peak effect is usually within about 5 to 15 minutes, but some of the main considerations with fentanyl include respiratory depression or apnea and bradycardia. There are some important considerations for a patient who's receiving a prolonged infusion of fentanyl. So fentanyl can build up slowly over time in the patient's fat tissues and thus lead to a longer half-life. Additionally, patients may develop tolerance, dependence, and then ultimately withdrawal when the medication is stopped. Over time, patients receiving fentanyl continuously are at risk for serotonin syndrome, which is a deadly adverse reaction, and it's characterized by altered mental status, neuromuscular hyperactivity, and autonomic instability. Moving on to specific sedative agents, Midazolam or Versed is a common benzodiazepine used for continuous sedation or conscious sedation for just a short-term procedure. So midazolam should be administered slowly. After administering midazolam IV, unconsciousness typically occurs within about 3 to 5 minutes. And as with most sedatives, midazolam can cause respiratory depression and even respiratory or cardiac arrest. Therefore, these patients need to be closely monitored and their airway protected. So what do I mean when I say airway protected? That basically just means that they may need an artificial airway like an endotracheal tube, or someone may need to be available to hold head tilt, chin lift, or jaw thrust to keep that airway open. Midazolam will often cause anterograde amnesia, and that just means that the patient may not remember some of what happens after the infusion begins until the drug wears off. And patients receiving midazolam are also at risk for tolerance, dependence, and withdrawal with a prolonged infusion. Note that patients who receive both fentanyl and midazolam infusions, which is a very common combination in the ICU, in those patients getting both drugs, we often see further CNS depression. Another key consideration of midazolam is that it can accumulate in the patient's tissues, especially when administered over a continuous period of time. So therefore, these patients may experience additive effects of sedation and prolong the time that it takes for the sedative effects to wear off. Another very common sedative is Propofol or Diprivan. Now, as with many strict sedatives, just like midazolam or Versed, Propofol does not provide any pain relief. This sedative is actually a lipid, and therefore it has an obvious opaque white appearance. Propofol is known for having a very rapid onset and offset, so it's very widely used. Now, once administered IV, you will often see the effects of Propofol within less than 60 seconds. However, these effects will typically only last about 3 to 5 minutes. Now, as with other sedatives, Propofol causes respiratory depression, but one unique thing about Propofol is that it can also cause hypotension. Therefore, one of the reasons patients are switched off of Propofol and onto a different sedative medication is that they present with hypotension. So any more Propofol would cause worse hypotension. Propofol can also cause metabolic acidosis, cardiac or renal failure, and can place patients at risk for rhabdomyolysis. Propofol is dosed using the patient's weight in kilograms, so we need to be sure to obtain an accurate weight before starting this drip. Now, one more key nursing consideration related to Propofol is that nurses should never administer Propofol boluses. The only time that a nurse can push Propofol in a syringe and bolus it for a patient, the only time that's appropriate, is if the physician is present and their hands are occupied and they instruct the nurse to administer that bolus. The last example of a continuous sedative we will discuss is called Dexmedetomidine or Precedex. Now, this is an alpha-adrenergic receptor agonist that can be used in intubated or non-intubated patients. Let me repeat that, intubated or non-intubated patients. When we talked about Propofol and Midazolam, those patients had to be intubated or at least have their airway protected, since one of the main risks of those drugs was respiratory depression or even respiratory arrest. One of the unique characteristics of dexmedetomidine is that it does not typically cause respiratory depression. So it can be used in patients who are very anxious or agitated, but we don't want to intubate them. Or they're already intubated and on the mechanical ventilator, but they're very anxious or agitated, and we need to take them off the ventilator. So dexmedetomidine is a really good choice when we need a patient to be calm, but we do not want to knock out their respiratory drive. So dexmedetomidine should typically only be used for the short term. Some sources recommend only up to 24 hours, others stay up to 72 hours or less. And dexmedetomidine is also dosed based on the patient's weight. So just like Propofol, we need to make sure we have an accurate weight before beginning the drug. Now, while this review of medications, again, is far from comprehensive, you can get an idea of some of the major considerations related to very common sedatives in the ICU setting. Once assuming care of a patient receiving any continuous drip, again, it is your duty to review that medication as well as the specific order and protocols associated with it. Not all protocols will follow common dosing ranges, but some familiarity of what to expect can be very helpful. In general, the American Association of Critical Care Nurses have outlined some important guidelines and best practices related to sedation. It's always important to treat pain before sedating a patient. If pain is well controlled, the need for sedation may either be negated or even minimized. Also, while sedation is very common in the ICU, always assess the actual need for sedation. In some cases, we can avoid continuous infusions, and we should always follow the principle of lowest possible dose to achieve the desired effect. When appropriate, daily interruptions in sedation or sedation vacations are an important part of nursing care. This is important for your patient's neurological function and can also minimize a number of risks, such as ventilator-associated pneumonia. Ultimately, while sedative medications can be very useful and even critical to the care of our patients, don't forget that there are other ways to establish a sense of calm for our ICU patients. Controlling lighting, noise, and stimuli can also promote calmness and affect sleep, which is important for our patient's healing process. Let's test your knowledge. For which patient is continuous sedation most appropriate? 1. A 22-year-old male complaining of chest pain and anxiety. 2. A 93-year-old female with end-stage leukemia and worsening delirium. 3. A 58-year-old male with a confirmed ischemic stroke demonstrating right-sided weakness and confusion. Or 4. A 51-year-old female with confirmed rib fractures who has just been intubated. The correct answer is 4. This patient has just been intubated and thus will be placed on a mechanical ventilator, a very uncomfortable experience that requires a state of calm. The other options do not present any key information that indicates a need for sedation. Just because a patient is anxious or has a serious condition, such as a stroke, does not mean the patient needs to be sedated. Also, many sedative medications can actually cause or worsen delirium. Now, regardless of all of these answer options, we should always evaluate the necessity of a sedative medication in any patient. Even if traditionally that patient may receive sedation, is it best for this patient and his or her entire clinical picture? Let's look at another question. A patient is mechanically ventilated and receiving continuous fentanyl and propofol infusions per protocol. Propofol is infusing at the max rate of 60 micrograms per kilogram per minute. The patient presents with a heart rate of 65, a blood pressure of 85/40, a temperature of 36.8 degrees Celsius, and a respiratory rate of 30, where the patient is initiating most of the breaths on their own. This patient appears agitated and the ventilator is alarming. Which is the nurse's best action? 1. Increase the propofol drip rate. 2. Decrease the propofol drip rate. 3. Discuss changing the sedative medication to Midazolam with the provider. Or 4. Discuss increasing the max possible rate for propofol drip protocol with the provider. The correct answer is 3. This patient is demonstrating one of the most common side effects of propofol, hypotension. Additionally, this patient is showing signs of agitation and needing to be further sedated. However, the propofol drip rate is already at its max dose. Not only can this patient not receive more propofol due to having reached that max dose, but increasing the dose any further could further lower the patient's blood pressure. The team needs to consider a different sedative medication that does not cause those side effects.